Okay, so good evening, everyone. I'm Talah Nammor. I'm currently a fifth year medical student, and I'm really excited to give you this session. Inshallah, tomorrow, come on, we're gonna go over pathology too and clinical questions. So for how will this go? I just have a question, okay? وبعدين we're gonna go over the answers, choose the most like perfect answer, and then we'll check the explanation. All right? I need you guys to interact with me because يعني I'm not gonna talk to the screen, okay? So let's start. So who's gonna read? حدا بده يقرأ ولا shall I read it?
I can read.
Okay, يلا.
So, 58-year-old woman presents to the clinic with muscle pain and weakness that began a few weeks after starting a new medication for her elevated cholesterol. Her history includes hyperlipidemia and hypertension. Physical examination reveals tenderness in the muscle of her thighs and calves. Lab studies show elevated serum creatinine kinase. Which of the following medications is responsible for her symptoms?
Okay, so she took a medication for cholesterol, تمام? And she now has problems in her muscle. What's your guess, guys? Let's see the chat. C, صح, it's statins. So basically, we know that statins, what do they cause? They cause, wait 1 second. So statins, they're known to cause basically muscle-related like myopathy, and they can even progress into more severe cases, which is rhabdomyolysis. And from the clinical scenario, you can see that she has elevated CK, which shows we have problems in the muscle. All right, perfect. Is this clear? It's easy, guys. It's up to the point. Yalla, next. Wait 1 second. تمام. خلاص I'll read it because هنا كتير كتار. Okay, so a 45-year-old man with a history of familial hypercholesterolemia is prescribed a new drug that inhibits proprotein convertase subtilisin kexin type 9, which is just PCSK9, all right? So a week after this therapy, he started having nasal congestion, but nothing else was wrong, all right? And his LDL cholesterol was levels, they dropped. So what do you guys think is the issue? What is the adverse effect that is associated with PCSK9? Do you guys have any guess? It's kind of like you can kind of tell from the question because he came with mild nasal congestion. So if we're talking about the nasal, exactly. So if we're talking about the nose, we think about, okay, maybe it's something like if you read from this hepatotoxicity, upper respiratory tract infection, myopathy, or hyperuricemia, the thing that's related to nasal congestion is upper respiratory tract infection. And yeah, PCSK9 is associated with injection site reactions, which is basically because it's given IV, so it can cause like thrombophlebitis, and it can cause upper respiratory tract symptoms like nasopharyngitis. And this patient came with nasal congestion, so you might think like you look at the whatever like the choices, and upper respiratory tract infection makes the most sense. You get me? Is this clear? Okay.
Yes.
Next. So a 58-year-old man is brought to the emergency department after experiencing crushing chest pain for the past 2 hours. Okay. So they did like an ECG and they saw that he had ST elevation, myocardial infarction, so STEMI. Due to the lack of access to percutaneous coronary intervention, he is treated with a thrombolytic agent. After administration of the drug, he develops a rash, fever, and hypotension. His condition stabilizes with supportive care, but laboratory test shows a drop in platelet count. Which of the following medication was most likely used in this patient? B, alteplase. Tamam. Do you guys agree? So let's think together. So he has rash, fever, and hypotension. Okay, someone said C. And a drop in platelet count. So the drop in platelet count can kind of give you like can redirect you into thrombocytopenia, all right? And because he has rash, fever, and hypotension, we can think that it's like a drug reaction. So it's like immunothrombocytic thrombocytopenia. Do you know it? The ITP? Do you guys know this? Anyways, C is correct, streptokinase, because streptokinase is basically it's derived from streptococci, which is basically It's a microbe, okay? So streptococci can cause allergic reaction, which can result in thrombocytopenia. All right. So what happens is that because of that allergic reaction to the streptococci that is inside the streptokinase, because streptokinase is kind of like an agent that is taken from streptococci. All right. So because it's derived from the streptococci, the body can have a hypersensitivity reaction to it, an allergic reaction to it. And this allergic reaction can result in the immune system attacking the platelets, resulting in immunothrombocytopenia. All right? Is this clear? Like all of the rest can cause other kinds of reactions, but this one specifically, because we have decreased platelet count, which is thrombocytopenia, we think about streptokinase. Clear? Okay, next. So a 55-year-old man with a history of coronary artery disease, hyperlipidemia, presented with flushing, itching, and warmth after starting a lipid-lowering medication. So guys, flushing, what is the first thing you think of when you see the word flushing? Niacin, exactly. So if in any question you see flushing, itching, and a lipid-lowering medication, the first thing you have to think of is niacin, because niacin is an amazing lipid-lowering medication, but it can result in flushing and warmth. So usually patients that like take niacin to decrease the lipids in their like system, they take before it NSAIDs to prevent the flushing. I don't know if this was mentioned, but this is an extra detail. I don't think they're gonna test you on that, but it's excellent. So whenever you see flushing and a lipid lowering medication, okay, perfect. So whenever you see flushing and lipid lowering medication, you directly think niacin. And they might ask you, like, if they want to be tricky, they might be like, oh, so he took this lipid lowering medication, he has flushing, what would you give to prevent this flushing? So we put NSAIDs, all right? So niacin, it causes flushing and pruritus because it's prostaglandin mediated vasodilation. Perfect. And it can be reduced by aspirin or NSAIDs. Perfect. Yellow. A 55-year-old woman with a history of recurrent deep vein thrombosis. Okay, so she has recurrent DVT. She's given rivaroxaban. And then after giving rivaroxaban, she reports that she has nausea, easy bruising, nosebleed. So these are things that she like developed after taking rivaroxaban. Okay, and then they did physical examination. They found petechia on her arms and legs. So exactly. Then they did their lab studies and they saw normal PTT and normal PT. And the platelet count is normal. So what happened? As everyone said, exactly. What happened is that rivaroxaban inhibited factor XA. And guys, it's so easy to remember rivaroxaban and direct inhibition of factor XA because from the name, there's an XA in the middle. So it's an XA inhibitor. Okay? So, and the coagulation studies are normal. This might be like tricky, but you guys, like it was literally mentioned in the question that rivaroxaban is given, so you have to directly know like, oh, factor XA is gone. Tamam? Okay. Moving on, a 52-year-old man with hyperlipidemia started on a bile acid sequestrant for cholesterol management, okay? Then he started having constipation and bloating. So what do you guys think is an additional adverse effect of these drugs? C. Perfect. Impaired absorption of fat-soluble vitamins. But can someone tell me why? They need bile because the bile was responsible for it. Exactly. So basically, those are lipid or fat soluble vitamins. So they need a lipid medium to kind of like make it easier for the body to absorb it. So that's why who else they said that we have constipation and bloating. So it kind of can make sense and we don't have fat soluble vitamins anymore. All right. So the bile acid sequestrants, which is cholestyramine, can impair the absorption of A, D, E, K, and cause gastrointestinal disturbances. Next. So a 72-year-old man with a history of atrial fibrillation, okay, ischemic stroke and recent coronary artery stent placement is receiving dual antiplatelet therapy with aspirin and clopidogrel. He presents to the emergency department with epistaxis and hematuria, so he's bleeding. And then the laboratory results will showed normal platelet count, so there's no issues with the platelets, but he has prolonged bleeding time. Okay, so they did genetic testing and they realized there is a polymorphism in the CYP2C19 gene. So what do you guys think is the cause of the epistaxis and the hematuria? C, increased risk of bleeding to dual antiplatelet. Okay. B, impaired clopidogrel activation. Okay, what do you guys think? A, aspirin resistance. So we have everything right now, A and B and C. طيب. I know it's aspirin. No idea, wallah. Okay. Guys, the biggest, okay, I understand aspirin and clopidogrel, both of them are antiplatelets, so they kind of will cause like bleeding. They can increase the bleeding time because that's what they're trying to do. They're trying to prevent the blood from clotting. Okay, but the biggest like kind of thing in the question that kind of gives you the answer is the polymorphism in the CYP2C19 gene, because this gene, okay, or this like CYP is important for the clopidogrel activation. So, okay, he's taking aspirin, but clopidogrel is not working because it's not being activated by the CYP2C19. You get me? So that's why the answer is impaired clopidogrel activation, because Aslan, they literally wrote in the question CYP2C19. You get me? And this is like the biggest giveaway to the answer, because I know like aspirin can be a cause of like, it can cause this, and maybe okay, we have two antiplatelets, so maybe the bleeding time is going to be increased. But no, the actual answer is impaired clopidogrel activation because of the CYP2C19. All right. And the doctor mentioned it in the slide, like in a very like a sneaky way, like in a very short place. You get me? Like, it was just mentioned like that. But I think, it's important to know such details because they can literally help you know like the answer. So clopidogrel, it's a prodrug. Because it's a prodrug, it requires the hepatic CYP2C19 enzyme to be activated. And since it's not activated, there is failure in the therapy. So even though the patient is on dual antiplatelet therapy, we're going to have bleeding risk is increased because of the suboptimal. Do you get me? Do you get the reason? So basically, he's a person who bleeds. So that's why, because clopidogrel is not working, it's not gonna help. Do you guys have any question regarding this? Okay. So next. So a 60-year-old man with a history of mechanical heart valve replacement started on warfarin therapy for anticoagulation. Okay? After 7 days, he develops spontaneous ecchymosis on his arms and legs and reports gum bleeding. His INR is elevated to 5.8. He admits to starting a diet that includes large amounts of green leafy vegetables. Which of the following best explains why his bleeding occurred despite the change in his diet? B. Exactly. So even if his diet has a lot of vitamin K, but warfarin is going to inhibit it. So it's not going to help. You get me? So warfarin will inhibit vitamin K epoxidase reductase, preventing the recycling of vitamin K that is needed for the activation of clotting factors. So even though he's eating like a lot of vitamin K, the inhibitory effect of warfarin persists, leading to an elevated INR and increased bleeding risk. Is this clear? Do you guys have any questions up to now? Oh, good. Okay. If anything's confusing, stop me at any time. Tamam? Okay. So A 63-year-old man with a history of unstable angina is scheduled for PCI. Okay? During the procedure, I didn't even read. During the procedure, he's given ABCXimab. I feel like, guys, once you see ABCXimab, you're gonna know what it does. So after he was given that, he still had bleeding at the catheter insertion site and his platelet count dropped. So which of the following adverse effects are observed in this patient? Okay. So can someone explain why? Like you're all seeing C, but why? Demo of the drug. Yeah, exactly. I feel like my questions are too easy. Did I go too easy on you guys? Maybe. Oopsies. Or maybe you guys studied really well. I think let's go with the second one. The questions are يعني أنا صراحة I wanted to remind you with the drugs more than anything because in the exam they're not gonna like trick you with the pharma inshallah يعني. Anyways, you guys were right. It's C. يلا next. So ABC أنا هيك حفظتها ABCXimab is a monoclonal antibody that inhibits the glycoprotein 2B3A receptor on the platelets, preventing platelet aggregation. That's why we can have bleeding. Specifically, if we have PCI, the vascular axis can start like leaking blood. تمام؟ يلا next. So a 60-year-old man with DVT is initiated on intravenous unfractionated heparin therapy. After 5 days of treatment, his platelet count drops by 50%, and he develops new onset painful swelling and erythema in his left leg, which now shows signs of ischemia. His coagulation panel reveals an elevated D-dimer and low platelet count. Which of the following is the best next step? Okay, I'm sorry. I'm gonna slow down. طيب, okay. تمام. So this patient, تمام, he presented with a DVT and then he was given heparin, okay, unfractionated heparin therapy. After he was given the heparin, his platelet count dropped by 50%. And then he developed basically painful swelling and erythema in his left leg. So basically he developed DVT again, all right? Or not DVT, but rather something that occluded the vessels. And then they did coagulation panel and they saw that he had elevated D-dimer and the platelet count is going down. So what would you do? Someone said D, administer protamine sulfate. Okay, so usually we give protamine sulfate when we have heparin toxicity or we have like a lot of heparin, right? Yeah, بس نحن هون the heparin, okay, the heparin, it's basically causing the platelets to decrease. Do you guys remember an adverse effect that causes, that's like related to heparin? Okay, exactly, heparin-induced thrombocytopenia. So if a patient comes with heparin-induced thrombocytopenia, what will we do? First of all, the first step is to stop the heparin. So we will discontinue the heparin. So A and D are gone. Okay, so it's gonna either be B or C. Tamam? Okay, and then we want something that will go directly into the platelet, tamam? Or like not the platelet itself, but directly into the thing that's causing the problem. So what will we use? Exactly, dabigatran, which is a direct thrombin inhibitor. So because the patient like had heparin-induced thrombocytopenia, what will we do? The first thing you do is you discontinue whatever, like heparin is causing the platelets to decrease in number. So we will directly stop the heparin infusion and then we're going to switch to another anticoagulant. Hala, why did we not switch into warfarin? Can someone tell me why? Exactly, because warfarin takes time. So نحن we know and we're going to discontinue the heparin. So it's going to be either B or C. And we have discontinue heparin خلاص, and then we want to see what will we put him on. So if we initiated the warfarin, it's not going to solve the issue, which is basically the painful swelling and erythema, and we even have ischemia, so we might actually lose the limb. So we want something that acts really fast. So what will we give? Direct thrombin inhibitor. Tamam? Is this clear? Okay. So you guys have to think this way, yani, because I know like when you in the exam you might look at like, oh, warfarin, and just choose warfarin because you know like we always know that warfarin is an anticoagulant and stuff like that, you know. But we have to actually think like properly before choosing. So see, in the question itself we have an acute like ischemia that is caused by a clot. Tamam. Next. So a 67-year-old woman with a mechanical mitral valve replacement is started on warfarin to prevent thromboembolism. She's also taking amiodarone for atrial fibrillation. After a month of the treatment, her international INR يعني is noted to be 5.2, so it's increased. She has no signs of active bleeding. Which of the following is the most appropriate next step in her management? So she's taking warfarin for protection from thromboembolism because she has a mitral valve, and she's okay, exactly, and she's taking amiodarone. So amiodarone and warfarin, we're gonna have drug-to-drug interaction, right? So we're not gonna administer vitamin K, obviously. We're not gonna administer fresh frozen plasma. What we will do is we're going to reduce the dose of warfarin and then monitor the INR closely. That's like the first initial step. You get me? Because if you look at the question, it says, what is the most appropriate next step in her management? You get me? They didn't ask you. Sometimes they trick you like that. So they didn't ask you, what are you going to do to the patient? No, what's your initial step or the most appropriate first step? You get me? No, increasing the dose is not going to help because we have, okay, wait, let's go next. So amiodarone will inhibit the metabolism of warfarin, okay, increasing the risk of elevated INR. So if we don't have active bleeding, what we do is we will reduce the dose of warfarin, and then we're going to monitor. So because amiodarone inhibits the metabolism of warfarin, we have increased warfarin. Tamam? So what we do is we're going to decrease the warfarin and look at INR. And as we mentioned, yes, exactly. So as we mentioned in here, there is no active bleeding, because if there was an active bleeding, we would directly give the bigotron because we wanted to stop it. Tamam? But because actually, isn't the bigotron thrombin inhibitor? So we wouldn't give it because it would exacerbate the bleeding. So D is wrong. صح? I love how I'm asking you guys, but yeah, like you. Exactly, like why would we wouldn't give the bigger trip? Because if you guys look at it, we don't have active bleeding, we don't have a clot, we don't have anything. So the only thing that makes sense is we reduce the warfarin and we look at the INR. If it improves, then khalas, we did the perfect thing. If it doesn't, then we might change the drug. All right? Is this clear? I'll double check the, like, you know, why did we not choose D? Because I don't think it would make sense to give her a thrombin inhibitor. Yeah, both are anticoagulants anyway. That's true. I feel like maybe, guys, B is the best choice. Like, I know that for a fact because as we said, there are no signs of active bleeding. Exactly, because no signs of active bleeding, there's no clot, there's nothing. So what would we do? We would just decrease warfarin and then check the INR. If it doesn't, if it improves, then khalas, we did the perfect thing. If it doesn't, we switch the drug. All right? This is more of like a clinical pharmacist question. Like, anyways, is it clear? Shall we move on? Okay, slay. Tamam. Now, a 62-year-old woman presents with the emergency department. She has STEMI, and she has a past medical history of hypertension, hyperlipidemia, but she never had any coronary artery disease. As the medical team prepares to initiate a fibrinolytic therapy, the attending physician reviews her medical history and notes several concerning factors. Which of the following findings in this patient's history would represent an absolute, like you would never, ever, ever give her a fibrinolytic therapy? D, active peptic ulcer disease. C, recent major surgery 2 weeks ago. طيب, let's think of it. Previous history of transient ischemic attack. Nah, like بالعكس, we would give her a fibrinolytic even if she had a TIA. Like that's how we treat a TIA, صح? We usually give them fibrinolytic therapies. We don't give fibrinolytic therapy if she had hemorrhagic, like a history of a hemorrhagic, let's say, like brain lesion. You get me? So A is gone. Then current use of anticoagulant therapy has nothing to do with like, would I give her like a fibrinolytic or not? Now we have C and D. So some of you guys said C and some said D. C or D. So, an active peptic ulcer disease. Okay, we know that peptic ulcers can bleed, but don't you guys think a major surgery recently? Exactly. So don't you guys think a major surgery is really, really like more detrimental than an active peptic ulcer disease? Yeah, and the question asks for an absolute contraindication. So يعني, you'd never give a fibrinolytic therapy. So if you guys were in the exam and you had two choices, just think of which one is more detrimental and which one I'd never ever give a fibrinolytic therapy for. And in this case, you guys are right, it's C. Exactly. So other contraindications will include intracranial hemorrhage and active bleeding disorders. But like peptic ulcer disease, guys, يعني, having a PUD doesn't mean that you have an active bleeding peptic ulcer, because peptic ulcer disease means maybe خلاص you just have peptic ulcers, it doesn't really, like it doesn't equal bleeding. And in this case, come on, the recent major surgery is more like detrimental and scary than an active peptic ulcer disease. And that's why it would be an absolute contraindication. Clear? Okay. Now, do you guys still think the questions are so easy? Okay, good. Tamam. So a 58-year-old male came to the emergency department with crushing substernal chest pain radiating to his left arm. So we're thinking of a cardiac arrest. His past medical history includes hypertension, hyperlipidemia, and stable angina. He reports that he usually experiences relief with sublingual nitroglycerine. Okay, and he used it for several years. On examination, his blood pressure is 130/80, and his heart rate is 88. Nitroglycerine is administered sublingually, and the patient reports significant improvement in his symptoms within a few minutes. So we're talking about angina. Hello? Which of the following is the likely mechanism by which nitroglycerine relieves the chest pain of the patient? So someone said B, someone else said D. But increasing myocardial, someone said B. طيب. So nitroglycerine, guys, how does nitroglycerine work? NO decrease oxygen weight. Okay, so nitroglycerine will release nitric oxide, which vasodilates. Perfect. So we look in here and we look which one will which of these will probably happen when we have vasodilation. So the venous return is going to decrease. Why would it decrease? Because the vein the vein is going to dilate and the blood is going to pool there. So the peripheral vascular resistance is going to decrease too. So صح, guys, it's B. And I want you guys to concentrate on something that's really important. You guys have to know that nitroglycerine causes venodilation. And when I say venodilation, I mean it acts primarily on the veins. Okay, and this is really important. So just keep it in your mind. Tamam? So it primarily works by dilating veins, which reduces preload and myocardial oxygen demand. So it basically reduces the myocardial oxygen demand. That's why it's not D. Tamam? Is that clear? Perfect. But guys, عن جد ركزوا on nitroglycerin equals venodilation. Because I'll tell you something later on, guys, حتى in your step 1, your step 2, they really care about this. And the nitroglycerin causes venodilation. So they might ask you about like arrows where they're like, oh, so like if we give them nitroglycerin, what will happen? So you guys have to think of the effect on the venous system, not the arteries, okay? Anyways, so a 65-year-old male with a history of ischemic heart disease presents to his cardiologist for a follow-up. He has been experiencing frequent episodes of angina despite treatment with nitrates and beta blockers. His cardiologist decided to start him on nicroandil, okay, a drug approved for angina treatment. After 1 week, the patient reports that his chest pain has significantly improved. So what's the mechanism of action of nicroandil? C, nitrate-induced vasodilation and potassium channel activation. Do you guys agree? C. You guys are right. So nicroandil is basically, it causes vasodilation via nitrate group and potassium channel activation, reducing preload and afterload. And you guys, it has N in its name, nicroandil. So it kind of makes sense, and it works on nitrates, just like how nitroglycerin. So N and N, so they work on nitrates causing venodilation. Okay, and this one has the dual action of كمان acting on potassium channels. Next, let's see. Okay, so a 60-year-old man with a history of chronic stable angina and hypertension is prescribed propranolol, and then he started having fatigue, shortness of breath. He also has occasional wheezing. He has a past medical history for asthma. What is the following explain? Okay, B. Okay. So you guys all know that beta blockers are contraindicated in patients with asthma. Why? Because it causes bronchoconstriction. It causes exacerbation of asthma. Bravo, guys. Specifically لأنه not all beta blockers, like specifically non-selective beta blockers, because propranolol will act on B1 and B2. But مثلا the specific beta blockers, like you can give them to asthma patients. But if it's non-selective, that's when you're like, no, I'm not gonna give it. It's gonna cause bronchoconstriction and it will make the asthma really bad. Yeah, next. هلا أنا I put long questions on purpose just to scare you guys, because that's what they do. They get you long questions that are really like, you look at it and you're like, oh my God. But then you read it and you're like, it's so easy. So for this one, the patient has stable angina and chronic artery disease. All right. He comes and he takes a lot of medications, beta blocker and a nitrate. But even though he's taking the beta blocker and a nitrate, he's experiencing chest pain. So his cardiologist is like, yalla, let me add ranolazine. And then after a few weeks, the patient reports a decrease in the frequency of his angina, but we have prolonged QT interval on his ECG. Why do you guys think we have prolonged QT interval? طبعا guys, like I'll give you like a trick that is kind of not a trick, it's obviously. Yeah, exactly. So basically, whenever the patient is on a drug and then miraculously هيك they gave him another drug, okay? And then he started having issues, always think of the other drug. طيب خلاص ranolazine. طيب فنحن عطيناه ranolazine and he started having prolonged QT interval. All right. So what explains the patient's symptoms? What is the drug, the mode of action of ranolazine, guys? I think you all said A. So it inhibits the late sodium current of the heart. Therefore, بصير في عنا decreased calcium and it will prolong the QT interval. Is this clear? I think it's easy, guys. It's just the mechanism of action of ranolazine. Am I moving too fast? I'm scared I'm losing you guys. أصلا إحنا كلنا على بعضنا we're only 6 in this. Okay, slay. Let's move on. So, a 65-year-old woman with a history of hypertension and angina presents for a follow-up. She started a new medication for 2 months. She reports that she's feeling fatigued and difficulty with bowel movements, which has worsened over time. And then her heart rate is 55 beats per minute. Her blood pressure is well controlled, and she doesn't have any chest pain or dizziness. Everyone's saying C. طب يلا explain, why is it C? Heart rate is decreased, okay. It also slows motility. Slay, صح. So exactly, verapamil, what does it cause? It causes constipation, it causes bradycardia, and you can see that this patient has hypertension, she takes a new drug, and suddenly she has constipation and bradycardia. So what do we think of? We think of verapamil. Bravo, guys. And why specifically verapamil? Because it's a calcium channel blocker, and it doesn't only work on the heart, it also works on the vascular smooth muscle. So what will it cause? It will cause the vascular smooth muscle to relax. So بصير في عنا constipation, وكمان it will cause the heart, like اللي هي cardiac muscle, to كمان relax, وبصير في عنا bradycardia. Clear? I think it's easy. Maybe I went too easy on you guys. ما حبت. Anyways, a 40-year-old man with severe hypertension is prescribed a medication. بعدين صار عنده سبحان الله facial coarsening and hair growth. Exactly, it's minoxidil. That's so easy because أصلا guys, anyone who wants to like grow their beard, anyone who wants to grow their hair, they usually take minoxidil. But if you see someone with hair growth, then it would only make sense when it's minoxidil. And it can cause palpitations and tachycardia, but we did not include them here. Okay. So a 45-year-old woman with a history of type 2 diabetes and microalbuminuria presents for management for her newly diagnosed hypertension. Her medications include metformin, glimepiride. Her blood pressure is 150/90. Lab results show normal renal function. Which of the following is the most appropriate first line? Bravo, C. Le. Diabetic nephropathy. Perfect. So now when we're trying to manage her what is it called, her type 2 her hypertension, we have to put in mind كمان انه what does she have other than her hypertension? She has type 2 diabetes, and we know for a fact that lisinopril has a protective, like nephroprotective abilities for people with diabetes. So that's why we give her lisinopril. تمام? So we have to, like, when we are trying to treat a patient with hypertension, we have to take it like, we have to look at various issues. We don't just look at the hypertension. Is this clear? So ACE inhibitors, they're the preferred first line. Why? Because they offer renal protection by reducing the intraglomerular pressure. Say. Next, so 28-year-old pregnant woman at 32 weeks gestation presents to the emergency with severe headache and visual disturbances. Her blood pressure is 170/110, and she is diagnosed with preeclampsia. The decision is made to start antihypertensive therapy. Which of the following medication is commonly used to treat severe hypertension in pregnancy? So we have an A and we have a C. If you guys look at this, all of these are used in pregnancy. Methyl-dopa, labetalol, hydralazine. I'm not sure about nifedipine. I don't think nifedipine is. Or I'm not sure, wait. But I know no methyl-dopa. Oh, it was briefly mentioned. The rest were more emphasized. Yeah, exactly. Like nifedipine, I think it is used. But no. So هلا نحن هون. We know that all of these are actually mentioned. So what will we look? We will look at شو اسمه, the mechanism of action, and see if the mechanism of action is right ولا لا. صح؟ So methyl dopa decreases sympathetic outflow by activating central alpha 2 receptors. Is this correct? Okay. Labetalol, non-selective beta blocker with, I think all of them are correct. Like the mechanism of action. But who the most correct answer in this situation is hydralazine. Okay. Because نحن هون we're having hypertensive emergency. It's 170 over 110. نحن we're not trying, this is hypertensive crisis. So we're not trying to kind of يعني control. بالعكس نحن we want immediate relief, and the immediate relief will be given by hydralazine, which directly acts on the what is it called, on the like the vessels, causing vasodilation, so it would decrease her blood pressure. Do you guys like get me? Do you get why it's hydralazine? So يعني نحن هون everything in here is correct, بس نحن we have 170 over 110 and she's pregnant and she has like preeclampsia. Your guys gonna take this later on. Preeclampsia is kind of dangerous. um like it can really go into like something called HELP syndrome, and we don't want to go there. Exactly, it can cause eclampsia, which leads to seizures. فنحن when we have extremely high blood pressure, we want to protect the mother and the baby, so we want something that's really really effective on spot. So we give hydralazine, which would cause vasodilation and increases nitric oxide. And remember how I told you guys, oh my God, nitroglycerine works on venous supply, it causes venodilation. Because شايفين هون hydralazine, it does the opposite. It works on the arterioles. It causes vasodilation of the arterioles. تمام? So nitroglycerine and nicocrandil, or whatever it was called, both of them act on the venous system, causing venodilation. But hydralazine كمان causes vasodilation, but of the arterioles. Okay? Is this clear? All good. Okay. Next, let's go. If you guys have any questions, you can stop me at any time. So, a 50-year-old woman with a history of primary hypertension and heart failure with reduced ejection fraction presents to her physician for a follow-up. She's currently taking metoprolol and lisinopril for hypertension, but her blood pressure remains elevated. The physician decides to add a new antihypertensive agent to her regimen. However, the physician wants to avoid a drug that could worsen her heart failure symptoms. Which of the following drugs should be avoided in this patient? D. Okay, I get what you guys are thinking, low sartan, because he's already on lisinopril. But guys, we were talking about something that would worsen the heart failure symptoms. So what does she have? She has heart failure with reduced ejection fraction. So if you think of it, the blood is pooling. The heart is not ejecting the blood. So C, exactly, verapamil. Why? Because if you guys remember, we said what would verapamil do? It would cause basically the vascular, what is it called? It would cause, it's a calcium channel blocker. It would cause bradycardia, right? So it's a negative inotropic effect. So what will happen? The heart is already like not pumping enough blood, and then we give it something that would even make it slower. The blood is never gonna work. This is gonna exacerbate the heart failure. تمام? Is this clear? That's why, guys, in the exam, don't directly like شفتوا كيف انتوا كلكم, everyone at the beginning you're like D. Like that's why slow down, read the question, because I know like D maybe is right because he's taking the lisinopril. Why would he take losartan? But the question wants specifically a drug that could make his symptoms worse. تمام؟ read the question properly لأنه أنا على فكرة, guys, I'm just like you. Like I would read something and I'm like, oh my God, I know this, and then I'll just put it وبعدين بيطلع غلط. Is this clear? Okay. Now, A 62-year-old man with hypertension, he started on a new antihypertensive medication, but after 3 months, he comes with frequent muscle cramps, weakness, and occasional dizziness. The laboratory results reveal the following. So his potassium is decreased, عندنا hypokalemia, his uric acid is increased, hyperuricemia, وعندنا hyperglycemia because of the glucose is increased. So what medication do you guys think he's taking? C. A or C, I forgot. صراحة queen. It's C. صح, guys, it is C. So basically we have hypokalemia, we have hyperuricemia, hyperglycemia. So what causes this? Thiazides cause those things, or they cause electrolyte imbalances. That's why it makes sense. Is it clear? This is just pure like adverse effect. شايفين the slide? Why not A? Can someone explain why not A? Yeah, let's see. It's a loop diuretic. Okay. Well, C is a thiazide. Okay. So the thiazides, what will they do? They will hyperpolarize the cells in the pancreas, leading to hyperglycemia. So what are the adverse effects of loop diuretics? Just to like ototoxicity, صح? And hyperkalemia. The hyperkalemia I'm not sure of, but ototoxicity is a very like high yield side effect. For you guys are right, but the furosemide hyperkalemia I'm not sure of it. Let me check. It's hypo. Okay, so it causes electrolyte imbalances. But I understand why you would have thought, why not furosemide? But what does it cause? It causes hypokalemia. It causes hyponatremia too. But if you look at here, the sodium is normal. But because the sodium is normal, you would be like furosemide, bye bye. You get me? Yeah. فلأنه sodium is normal, you'd not think of furosemide and you directly think of hydrochlorothiazide. تمام? Is this clear? خلاص, can we move on? Okay. تمام. هلا هون 55-year-old male with a history of chronic kidney disease and hypertension. He has been struggling with wait, what did I do? Guys, do you see my screen? Wait, what did you say? Yes. طب أنا ليش ما I see my screen? I can't see my screen. Wait. Okay, I know what I did. Never mind. Wait 1 second. No. ضيعت الفيديو. ولا ما ضيعته. Wait. Guys, do you see my screen or do you see the Zoom thing? اوكي بحب انه جاوبته وانا لسه ما قرأت السؤال ده. No, I don't want that. Okay. I'm sorry guys, بس ما اعرف شو صار. دقيقة. We see your screen. Okay. But the issue is but like I don't want that. طب خلاص whatever. Anyways, نرجع للموضوع. So عندنا chronic kidney disease. He's been struggling with uncontrolled blood pressure despite treatment with a combination of an ACE inhibitor and a calcium channel blocker. Guys, wait, there's something wrong. Can I just see something? No. participants. I'm sorry guys بس دقيقة لأنه I don't know what's wrong but I can't see your chat. It's not what I want.
Would you like me to pause the recording for a second?
Wait. Yeah, just for a second. Okay. So let's go back into this question. Oh, it's easy. That's why everyone answered really fast. Okay, so basically, a patient has chronic kidney disease, hypertension. He's taking ACE inhibitor and a calcium channel blocker, but then it did not work out. For his doctor changed it to Alice Chiron. What is Alice Chiron, guys? I don't even know if I'm spelling it correctly, but I'm assuming that's how we spell it. Alice Chiron. So renin inhibitor. Okay. So when we say renin inhibitor, what does renin usually do? Convert angiotensin 1 to angiotensin 2. Isn't this an ACE inhibitor though, guys? No, that's, yeah. So renin is before ACE, angiotensin 1 and angiotensin 2. Exactly. Renin, it usually helps in the formation of angiotensin 1 from angiotensin, I don't know what is from like the primary one. I'm not really sure how to spell it. Okay. What will happen is angiotensin 1 is not going to be formed. Therefore, where the progression of the RAS system is not going to happen. Clear? This is a very easy question, يعني الصراحة. Slay. Yalla, next. A 58-year-old male with ventricular arrhythmia is started on antiarrhythmic agent that prolongs the action potential duration and the effective refractory period by blocking potassium channels. And then he started having, it's effective for atrial and ventricular arrhythmias. However, the patient is warned about potential thyroid and corneal deposits. Yani guys, I gave you mode of action and side effects. And this is the easiest question on the planet. صح, amiodarone. So the corneal deposits are associated with amiodarone. The doctor can easily get you like, you know, like he can say and no, he can show you the corneal deposits and he'll be like, okay, so what's the mode of action of the drug that was given that caused this? So what would you guys say? What is it? I love the silence. Potassium channel blockage. Exactly. So the doctor can easily get you the image of the corneal deposit and he'll be like, okay, or مثلا he's asked, what class is this? So it's class 3. So it would block the potassium channel and it can cause, as mentioned, thyroid dysfunction. Is this clear? It's easy, guys. I just wanted to remind you of the action. So don't forget, amiodarone, potassium channel blockage can cause thyroid dysfunction or corneal deposits. That's all you need to know. Hello, next. So basically, a 72-year-old male with chronic heart failure and a resting heart rate of 85 is prescribed a drug to reduce his heart rate. After a few weeks, he reports experiencing episodes of visual brightness and seeing brief flashes of light. His medication inhibits the funny current in the sinoatrial node to reduce the heart rate without affecting the contractility. So it's something that only affects the heart rate. Okay, someone's saying C. Is this ivabradine? I don't know. You have to tell me. So what is a drug that acts on that inhibits the funny current and it causes flashes of light? They basically said the side effect. Exactly. So it is phosphine phenomena. صح, you guys are right. And as your colleague mentioned, it is ivabradine. So ivabradine is a funny current inhibitor, and it usually causes visual disturbances such as phosphines. where you can see basically, okay, you feel like the light is always like bright. Or I don't know what do they mean by a sensation of visual brightness, but like yeah. Is this clear? It's easy, guys. Stay. So, a 70-year-old male with a history of chronic heart failure and atrial fibrillation is started on a new medication to control his symptoms. Several weeks later, he presents to the emergency describing yellow halos around the light. His EKG shows bradycardia, and we have prolonged PR interval. His serum potassium level is 5.6, which is, guys, increased, okay? It's hyperkalemia. Okay. Slay! Because we gave you Awashi, we gave you the way the... طب guys, is that the mechanism of action was not given? Would have you known it's like digoxin? Why? Because of the hyperkalemia, obviously, and the yellow halos. Exactly. Guys, do you know that that's a fun fact? So I read it recently, and no, basically, guys, do you see how like what is it? Van Gogh's like drawings, especially his last drawings before he died, how they all have like yellow color, like hey, they're all yellowish. So basically it's because of the digoxin toxicity, like he was taking digoxin for his like heart. Because of that, he started seeing everything yellow. He drew everything in the like the hues of yellow. It's a very interesting fact, صراحة. I don't know if you guys are fascinated by the fact too, but yeah. When I read it on Twitter. So random, but yeah. And I figured this yellow halos, it has like a scientific name. I'm not sure. Like ما حافظة the scientific name, but it's like it's really interesting. So as we said, toxicity presents with GI disturbances, visual changes, which are the yellow halos, bradycardia, and hyperkalemia. Is this clear? بس توقعتوا تكونوا مثلين هيك تعملوا لي رياكشن لما احكي لكم عن فان جو، بس ما حدا عمل لي رياكشن. ما حبيت. It's called something xanthopsia, like something like that. Wait, let me get it. Yellow halos, digoxin. It's called yeah صح xanthopsia. Wow. Slay. And altered color vision, which is chromatopsia. Anyways, شكرا guys انكم ما عبرتوني على the Van Gogh thing, بس next. It was a nice story. بحب انه عم تحاولوا ترقعوا. خلاص زعلت. المهم next. A 65-year-old male with a history of hypertension and type 2 diabetes is diagnosed with heart failure with reduced ejection fraction after presenting with fatigue, dyspnea, and ankle edema. His ejection fraction is 35% and his blood pressure is 140/85. The physician decides to initiate heart failure therapy aimed to improving mortality. Which of the following combination of drugs should be initiated to best reduce mortality and hospitalization in the patient? Someone said B. B. Okay, you guys are right. Should also have ARNI, but they must have forgotten to write it. What is ARNI? Oh, you mean ARBs, like ARB inhibitor? Oh, صح? ARNI. Ah, nicotinamic inhibitor. Ah, yeah, okay, okay. It is B. It is B. You're right. But yeah, probably هلا هو لأنه the question is aimed at like improving mortality and hospitalization, and this is usually the protocol, and then they added neprilysin, you get me? So ACE inhibitor, beta blocker, and mineralocorticoid receptor antagonist. Wait, ARNI is you see, it usually includes an ACE inhibitor, an ARBs, or an ARNI with a beta blocker and mineralocorticoid receptor antagonist. I think it's or, it's not and. يعني you can either have ACE inhibitor or the valsartan and scubitarol or whatever it is. The slide said and. Actually, okay, I'll double check this information الصراحة. But if the slide said so, then خلاص, just go with whatever the slide said. But the issue, like for me, the issue is in ACE inhibitors and those two, they act the same way. Why would you have both? You get me? Like I think you'd either do ACE inhibitors or that. Because if you think of it, it's the same mechanism of action. Like not يعني exact same mechanism of action. No, you only pick one with the sacubitril. ما عم بفهم. Like you mean, but like if we have an ACE inhibitor, why would we pick the one with the sacubitril? But listen, guys, I'll double check that and I'll send it. Like when I send my PDF, okay. When I said the the slides, I'll add like a discussing this, okay? But if it's wait, and you give it with either an ACE inhibitor or an ARB. Oh, okay. So معناتها this is probably just missing an neprilysin inhibitor. So it's like ACE inhibitor أو ARB مع the neprilysin inhibitor, beta blocker, and mineralocorticoid receptor antagonist. Is this clear? I'm sorry if I confused you guys. But أصلا if you look at the wait, sorry. If you look at the rest, like it's not even mentioned. Yani the answer is this regardless. You get me? Yani you can see no, it's not gonna be ARBs and diuretics or diuretics and digoxin or ARBs and ivabradine. So you just go with B. تمام? I think it's clear. يلا next. تمام. So the patient, he has a heart failure with reduced ejection fraction and he's taking spironolactone. طيب, but then he has gynecomastia. What would you do next? Someone's saying A. What do you guys think? A. The boy A. Has a similar structure to the hormone, so that's why. Exactly. So the gynecomastia is caused by the spironolactone. So what we do, we would stop the spironolactone and we would give rather eplerenone. Hello? Because eplerenone like is a diuretic كمان, but like it wouldn't cause the gynecomastia. صح, it would cause amenorrhea in women. Slay. Shall we move on? Okay. So spironolactone can cause anti-androgenic effects such as gynecomastia. That's why we would give eplerenone, which is a more selective mineralocorticoid receptor antagonist, without these side effects. Stay. تمام. We have a patient with heart failure. He comes, he has shortness of breath, orthopnea, and bilateral rales. His blood pressure is 160/95, and his oxygen saturation is 88% on room air. He's diagnosed with acute decompensated heart failure. Which of the following is the most appropriate initial management for this patient? So he has blood pressure. He has blood pressure. He has heart failure, and his blood pressure is really high. So what would you do? B. طب why? ليش مثلا ما بعطيه a loop diuretic and I'll see for his response مثلا. We need both. We need IV. Okay. تمام. Why do we need okay volume overload? Perfect. That's the word that I want. So we have what is it called, heart failure, and you can see because of the way he's presenting with hypertension and the acute shortness of breath, we can see that we have decompensated heart failure, right? فلأنه عنا decompensated heart failure, what we want to do is we wanted like kind of أولا we want to decrease the blood pressure. That's why we would give the nitroglycerine to basically cause the the venodilation, and we want to get rid of all of the volume, the volume overload that we have, all of the fluids, because if you guys see like shortness of breath and orthopnea means we're piling up fluid in our lungs. So we want to get rid of all of these fluids. So what we do, not loop diuretic, which is IV furosemide, which would really act fast, and the nitroglycerine to decrease the blood pressure. Inshallah guys, 10 out of 10. يلا. So عنا African American male with a history of heart failure. He presents for a follow-up. Despite being an optimal medical therapy with ACE inhibitor, beta blocker, and diuretic, his symptoms have not improved and his section remains low. B صح. Why B? What is the keyword? African American. Slay. Proud of you guys. دارسين منيح there final. طيب a 50. Oh, my questions are easy. Like it's either this or that. But I'm gonna think that you guys are studying well. خلاص. It's the better choice. Anyways, a 58-year-old male with a history of heart failure presents to the emergency department with acute decompensated heart failure. Hello, he has been on Convertilol and Lisinopril at home, but he now presents with dyspnea, orthopnea, and rails on physical exam. So his blood pressure is kind of high, heart rate is 105, and oxygen saturation is low. The decision is made to stop one of his medications temporarily. Which of the following drugs should be held until the patient is stabilized? C. Why? We lost someone. Oh no. Yeah, we did. No, we didn't. Anyways, why do you guys think it's C? Or do you have any other answers غير C? Decompensated. Okay. So it's, you guys are right, it is C. But why do we not give held as in stopped? Yeah. We don't give him B. Okay. So he is already taking carvedilol and lisinopril. Okay, and he has acute decompensated heart failure. So this means when we have acute decompensated heart failure, we're going to have volume overload. And what does carvedilol do? It is a beta blocker, right? So because it's a beta blocker, what will it do? Negative inotropic. Slay. So because negative inotropic, it's going to cause bradyarrhythmia. Not brady, yeah, bradycardia. يعني. So we're going to have bradycardia, and this is going to just make everything worse. So what will we do is, and we're going to stop carvedilol to not exacerbate what we already have. Hello? Is this clear? Okay. Next. 45-year-old man with a chronic asthma is prescribed medication to manage his symptoms. He presents to the clinic later with restlessness, insomnia, and palpitations. His heart rate is 110. Blood tests reveal elevated levels of the medication. So what do you think it's the medication? B. B. Is it so easy, guys? أنا على فكرة لما كنت عم جهز the thing, I don't even remember theophylline, but but you guys are right, it is theophylline. Theophylline causes CNS excitation or stimulation. They mainly use it in ER. Okay, so it causes CNS stimulation, and because it causes stimulation, بصير في عنا tachycardia, and when you're stimulating the brain, obviously you're not gonna be able to sleep. It's like caffeine. Yep. Methylxanthine is basically, the caffeine is the caffeine in coffee is considered a methylxanthine. صح. Wow. Okay. يلا next. A 40-year-old woman with moderate persistent asthma uses a short-acting beta agonist for quick relief of symptoms. However, she continues to have frequent nighttime awakening due to asthma exacerbations. The physician decides to add a long-term control medication to her regimen that would inhibit phospholipase A2 and reduces inflammatory mediators. طيب, when we inhibit phospholipase A2 and reduce inflammatory mediators, what are we doing? Inhaled steroids, exactly. So basically, we're kind of like shushing the immune system. We're telling them to shush. Lipoxygenase is inhibited. Which one of these are like a corticosteroid or a steroid? C. Slay, guys. صح. So beclomethasone is an inhaled corticosteroid that reduces the airway inflammation by inhibiting phospholipase A2. Next, so a 35-year-old woman with a history of asthma presents to the emergency because of an acute asthma exacerbation. She's treated with a short-acting beta-2 agonist via a nebulizer. However, she reports having palpitations and muscle tremors, and the blood revealed having hypokalemia. So what would you think it is? Guys, it's easy. Like, we literally said hypokalemia, and in here... Okay. B. It is B. Like, obviously, it causes potassium influx. But what is... Okay, I kind of showed it to you. Okay, so beta-2 agonists, what do? They do increase cyclic AMP and they cause bronchodilation. Thus, they also cause the potassium to go into the cell. What would we have? We would have hypokalemia. And hypokalemia would present as tremors. So if we go back, they also act on kidneys, I think. That's why. Yeah, the potassium is in the kidneys. Like the activity of, I think the potassium is in the kidneys. So, yeah. Yeah. So, what is it called? If we see palpitations and muscle tremors, what would you think of? You would think of beta blockers and hypokalemia. Okay? Is this clear? صراحة, this question is really easy. I don't like it. I don't know why I put it. Whatever. Okay. So 48-year-old woman with severe eosinophilic asthma. Eosinophilic asthma. So what would we give, guys? I'm not going to complete the question. وعندنا interleukin 5. It's an interleukin 5 inhibitor. Someone said C. Someone said C. Are you guys sure? We're talking about an inhibitor. An interleukin inhibitor. What does montelukast do? A for IgE. طيب, A is gone. It's not IgE. نحن we're inhibiting interleukin 5. And it's a monoclonal antibody, guys. So it's not montelukast. Doesn't montelukast act on mast cells? I'm actually disappointed. امزح. بس صح, montelukast, what does it act on? Leukotriene inhibitor. Isn't montelukast a mast cell? No, that was cromolyn. It is a leukotriene inhibitor. Yeah, it is a leukotriene inhibitor. It's called singular. That's all I remember. It's cromolyn, yeah. Cromolyn is a mast cell stabilizer. And montelukast is a leukotriene inhibitor. And in here, we're talking about interleukin, not leukotriene. Leukotriene is LTB or LTE, or whatever. We said monoclonal antibody. يعني مثلا, guys, this is another way of trying to solve a question. If you don't know, like, actually, it's basically it's B. تمام? It's B. So it's either هلا نحنا let's see the question. So it's a monoclonal antibody. Monoclonal antibody, and it ends with MAB. So it's not C or D. As easy as that. So if we said omalizumab acts on IgE, so it's not A, so it's B. Well, no, I didn't read the question. Oops, guys. But you get me? Monoclonal antibody. So it's MAB. So it's either A or B. Omalizumab acts on IgE, so gone. So it's mepolizumab. And it's the only interleukin 5 that you guys have in your lecture. Roflumilast. Where is it used? Does anyone remember? It's mentioned for a very specific disease. No. COPD. Yeah, it is COPD. So roflumilast, I don't even know how to say it, is mentioned for COPD specifically. And here we're talking about eosinophilic asthma. So yani, it kind of makes sense. No, it's not the right answer, you know? I'm just giving you guys tips and tricks to try to think even because I'll be honest with you, Anna, for me, pharma is one of the worst things ever, to be honest. Specifically like this pharma. It would make sense sometimes because of the like huge amounts of drugs you have to guys memorize. It would make sense for you why you forgot it. But try to like incorporate this into solving. Yes, I'm sorry I'm talking a lot. تمام. فإذا asthma, directly think of mepolizumab, interleukin 5 inhibitor. Next, so we have a woman with persistent asthma. She comes with worsening symptoms. She reports that her asthma flares up whenever she takes aspirin, and she frequently experiences wheezing and shortness of breath during exercise. Her current treatment includes an albuterol inhaler as needed, but she requires additional control. The physician decides to add an oral medication that targets key mediators in asthma, reducing airway inflammation and bronchoconstriction. So we have a D and we have a B. Okay. Let me see D. Why do you guys think it's theophylline? B. B for aspirin. Okay, let's go through roflumilast. We said it's used for COPD, so it's not in here. So gone. Salmeterol is it's basically a beta blocker, so it's gone. And then we have theophylline. We said theophylline. Okay, they're saying B. So, but tell me, why is it not theophylline? Why not? It's not long term. Slay, خلاص. So it's B. And they mentioned in here no, it targets a key mediator in asthma, reducing airway inflammation and bronchoconstriction. So you can guys think of like, what is it called? Of leukotriene, because leukotriene is what causes the inflammation and the bronchoconstriction. A very important mediator in asthma is leukotriene. What would affect leukotriene? Montelukast. So here you go. That's the answer. Montelukast is a leukotriene receptor antagonist, particularly effective for managing asthma triggered by aspirin sensitivity and exercise. Is this clear? So if you guys see exercise, aspirin, if you see bronchoconstriction and something that mediates it, just montelukast directly, because leukotriene is the thing that causes all of this. Is it clear for everyone? I'm scared I'm going too fast. I only have you guys, like the 4 of you, for any. I need you all to tell me it's clear. Okay. طيب. تمام. يلا. عنا a male that has COPD. Okay. Despite using inhaled bronchodilators and corticosteroids that lead to hospitalization, the physician decides to add a medication that targets inflammation by inhibiting phosphodiesterase 4 to reduce the frequency of exacerbations. 2 months after the medication, he returns to the clinic with diarrhea, weight loss, and loss of appetite. Yara is saying C. Do you guys agree? يعني صراحة صار لي ساعة عم لكم COPD is rough last, so يعني it makes sense. Okay, so rofimilast is a selective PDE4 inhibitor that's used specifically in COPD, and it can cause. Guys, I'm pretty sure this is literally the only like medication that's mentioned in COPD عندكم بالlecture. فيعني if you see COPD, just choose it. Let's read the question. يعني مشان later on you're like, Talah, because of you we lost a mark or whatever. I'm not gonna be held accountable. Anyways, a 45-year-old woman with idiopathic pulmonary arterial hypertension presents for a follow-up. After several months, her symptoms improve, but she reports mild peripheral edema and fatigue. So we have peripheral edema and fatigue, and we have mildly elevated liver enzymes. So we have hepatotoxicity. Which of the following drugs is most probably prescribed? C, bosentan. You guys are right. I want you to give me another important thing to consider when we have bosentan. So, okay, guys, what is the mode of action of bosentan? I can't remember. طب أول شيء mode of action endothelin receptor endothelin receptor inhibitor. Yep, صح. Slay. So it inhibits the endothelin receptors. طيب, what is something else that مثلا a woman should keep in mind when she takes bosentan? Tetragenic, exactly. So basically, it's highly tetragenic, and she has to take double. You're saying right, OCP صح. She has to take double protection. يعني she's probably like OCP and something else. تمام? So it's an endothelin receptor antagonist. It blocks ETA and ETB. It causes vasodilation. It is known to cause peripheral edema and hepatotoxicity, which requires monitoring. Excellent, guys. Inshallah, you guys are doing amazing. A 45-year-old woman with advanced pulmonary arterial hypertension is on continuous epopristol infusion via a portable infusion pump connected to a central venous catheter. She presents to the hospital with acute worsening of her symptoms, including several shortness of breath and dizziness. Upon examination, it's discovered that her infusion pump malfunctioned and she has not received her medication for several hours. Which of the following is the most immediate complication of discontinuation of prostacyclin therapy? What do you guys think? A, D, no idea. Okay. Okay, epoprostenol. What epoprostenol? It's a prostacyclin. Okay, epoprostolone. It is a prostacyclin. So what do prostacyclins do? Keep the bloody cyclin. What do you think? The bloody cyclin. طيب, keep the blood cycling. Okay, listen. So prostacyclins, they cause vasodilation. Hello? So that's why we give them for people with pulmonary arterial hypertension, because we want them to have the vasodilatory effect. So إذا نحن we remove the vasodilatory effect, what's the first thing that's gonna happen, guys? In the lungs. Why do I care about the systemic? We're doing it like we care about the lungs. So I know I think this is not even mentioned in your مثلا lecture, or like it was mentioned in another way, but yeah, so it's going to cause acute rebound pulmonary hypertension, because think of it, we're giving them something that's going to cause vasodilation, and it's going to kind of relieve the tension from the lungs. If it's gone, and aslan, if you guys look at the symptoms, she has worsening of her symptoms, shortness of breath and dizziness. So what would you think? You won't think of systemic hypertension for shortness of breath, صح? You can't think of acute thromboembolism and like she has a PE, but like there's no indication of a PE whatsoever. For why would we do B for not B? Catheter related infection? No, like why would an infection cause specific, is like if it's catheter related, it's not gonna cause what is it called? Directly, it would cause مثلا something in the lung. It would probably cause something that's like it can cause septic shock because it's directly into the blood. It's not B, it's not C, and systemic hypotension is not gonna directly cause shortness of breath and dizziness. It can cause dizziness, yeah, but like it would make the most sense. And no, the pulmonary hypertension came back. So we're going to have acute rebound pulmonary hypertension. And that's why we would choose A. Is this clear? So abrupt discontinuation of prostacyclin therapy, such as epoprostenol, can lead to acute rebound pulmonary hypertension, which can be life-threatening. So the idea, again, guys, to make sure that you guys understand it, prostacyclins, they cause vasodilation. The blood is cyclin is actually a mnemonic in use. Okay, I'm sorry if I made fun of it. But I never heard of it, that's why. I feel bad now. My apologies to you. but it's true. It causes vasodilation. Oh my god, I feel bad. I'm sorry. Anyways, شو اسمه? You're right. It causes فبصير عندنا vasodilation, and because the blood is cycling, we're going to have basically rebound pulmonary hypertension. تمام؟ لأنه نحن قمنا this vasodilation. We removed the vasodilatory effect. So the pulmonary hypertension is like, hello, I'm back. So we're gonna have rebound hypertension. Okay. حاسة يا عم تقولي oh good يعني يلا خلصينا. I'm sorry. Anyways, a 40-year-old male with a history of chronic bronchitis. Hello? Presents with a dry persistent cough. He's prescribed an oral medication that reduces cough by decreasing the sensitivity of cough receptors and suppressing the medullary cough center. The drug acts through sigma receptor stimulation and is structurally related to codeine with fewer sedative effects. C. Yeah, guys, A is contraindicated. صح. C, because it is related to codeine and it acts on the sigma receptor. Like I literally gave you the mode of action and you guys knew it's dextromethorphan. Wait. Slay. So dextromethorphan suppresses the cough by acting on sigma receptors. Blah 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 blah. It's structurally related to codeine. Like we literally gave you all the like hints to know which one it is. طيب. A 6-year-old boy presents with fever, ear pain, and decreased hearing. So إذا عندنا fever, ear pain, decreased hearing, we think of otitis media. But then we did otoscopic examination and we saw a bulging erythematous tympanic membrane. So he was actually like diagnosed with acute otitis media. The physician will prescribe the first line treatment for this bacterial infection. What do you guys think is the first line treatment? Someone said B, E. What do you guys think? Is it B? Although they're becoming resistant to it, but B. That is true. But like, it is the first لهلا يعني even if they're getting resistant لهلا it is the first line of treatment because guys, what are the possible microbiological like organisms that can cause otitis media? Like give me 3. Actually, don't give me 3, just give me the most common. What is the most common? صح موركس وهن الثري اللي هو موركسالس سودوموناس and ما اعطيتوني اللي بدي اياها. هي the most common. Strep pneumo. Staphylococcus. No, guys, something that's so specific for otitis media. Do you guys remember the skachil, the baby that's holding his ear? Was it not more? Wargzilla causes that, but it's Haemophilus influenza. The one that I really wanted, yeah. But who the 3 most common is Haemophilus influenza, streptococci pneumonia, and Wargzilla. You're right. Is this clear? This was mainly HMS. Yeah, true. But I don't know why you guys have like antibiotics for the upper respiratory. I don't know what. Anyways. تمام. So a patient has allergic rhinitis and he is seeking relief from nasal congestion. She's prescribed a sympathomimetic nasal spray that provides rapid vasoconstriction to the nasal passages. The physician advises her to limit the use to a maximum of 2 to 3 days to avoid a non-complication of prolonged use. Which one is it? Yeah, rebound congestion by phenylephrine. طب ليش مو B, guys? Because pseudoephedrine is also a sympathomimetic. Why do you guys not choose B? It's a spray, so local. Okay, also 2 to 3 days only. Okay. But come on, another thing. Does pseudoephedrine does it cause hypotension? It reduces hypertension. Does it reduce hypertension? Relax, it causes. Exactly. That's why B is not correct. I'm just trying to tell you هلا انتوا اللي حكيتوه كلكم صح. Like A اصلا it makes sense. Like something that's very known 2 to 3, so complication of prolonged rebound to congestion directly. But saying in case مثلا in the exam you looked and you're like, ooh, pseudoephedrine is a sympathomimetic too. Why should I not put B? It's because the complication is wrong. So read the complication too. Ooh, C and D, like they're not sympathomimetic drugs, but that's why not C, not D. Anyways, today guys, you're doing amazing. Rhinitis medicamentosa, which is the rebound congestion. I feel like Dr. Dilip loves this. I don't know if he got a question on it for us for our exam صراحة, I forgot, but it's kind of like really like هيك. Yeah, exactly. I think it was mentioned before because he really likes it and it's really like catchy صراحة, guys. Like whenever you hear it, you're like, oh my god, it's phenylephrine. Anyways, a 35-year-old female with persistent allergic rhinitis reports inadequate relief from oral antihistamines. So she's experiencing ongoing nasal congestion and rhinorrhea. The physician prescribes a nasal spray that stabilizes mast cells. صح. Cromolyn is a mast cell stabilizer. Slay, guys. تمام. عنا a 65-year-old male with a history of chronic obstructive pulmonary disease. It's admitted for community-acquired pneumonia. He's started on levofloxacin. After 5 days of treatment, his symptoms have improved, but the laboratory results show an QT interval is increased. Which of the following best describe the mechanism of action of levofloxacin and what genetic mechanism might be responsible for the resistance if the patient developed resistance? So what do you guys think? What is the mechanism of action of levofloxacin? A or B? What do you guys think? Is it A or B? أولاً, what's a levofloxacin? It's a fluoroquinolone. Okay, fluoroquinolones, they don't act on protein synthesis, so it's not B. Inhibition of folate synthesis? No, because no. Inhibition of cell wall synthesis and penicillin binding proteins? No, that's like أكيد لا. Exactly, it's inhibition of bacterial DNA gyrase. Another name to it is topoisomerase, guys. But okay, they can trick you with saying DNA gyrase. You guys are right. It is A. So fluoroquinolones like levofloxacin, they work by inhibiting DNA gyrase, which is topoisomerase 2. And they will, it makes sense enough for them to, like the mutation, where would it be? It would be in topoisomerase. Or they can have efflux pumps, but more commonly it's due to mutations in topoisomerase. Is this clear? Okay. Say, guys. طيب, a 70-year-old male develops fever, purulent sputum, and respiratory distress 72 hours after being admitted to the ICU. Chest X-ray reveals a new infiltrate in the right lower lobe. The patient is intubated and the sputum cultures are pending. Given the high likelihood of a hospital-acquired pneumonia because he's hospitalized because of a stroke, what do you guys think the empiric therapy should include? Someone said A, cifepime and azithromycin. A. But before we to cover both typical and atypical. So, okay, before we go, what are the organisms that causes hospital-acquired pneumonia? What are they? هن ثلاثة that are really important. Pseudomonas, حلو. Staph, which is basically MRSA, okay. So Pseudomonas and MRSA. طيب, هلا MRSA, would it be covered by cifepime أو azithromycin? No. طيب, لكن ليش حطيته A? Then B. Exactly. So it is B. Because when we think of hospital-acquired pneumonia, we have to think of MRSA. And cifepime and azithromycin, they don't cover MRSA, so we wouldn't choose it. So when we want to treat empirically the hospital-acquired, we think of Pseudomonas, so we would give piperacillin and tazobactam, and MRSA, which is treated through vancomycin. Is this clear? تمام. Next, a 52-year-old man with a history of HIV and a CD4 count of 150 presented with hospital-acquired pneumonia, and his physician is concerned about the possibility of an opportunistic infection. The patient's respiratory cultures reveal Pseudomonas and Pneumocystis jirovecii. The physician prescribes an incorrect regimen. B. Why B, guys? And صراحة it's very obvious why B. Because the trimethoprim and sulfamethoxazole is used for pneumocystis jirovecii. صح, guys. Perfect. You're doing amazing. Okay, I'm sorry, this looks horrifying, but it's easy. A 45-year-old male is diagnosed with acute pulmonary tuberculosis, okay? And he is given isoniazid. After 2 months, he reports numbness and tingling in his hands and feet. So we have peripheral neuropathy. Which of the following best explains the mechanism by which isoniazid causes the peripheral neuropathy, and what could we give to prevent? A. Okay, yeah, you're right, guys. It is A. So it inhibits pyridoxine phosphokinase, and that's why it causes peripheral neuropathy. And when we give pyridoxine, it can actually prevent this. Next, a 29-year-old pregnant woman is diagnosed with multi-drug resistant tuberculosis and prescribed a regimen that includes streptomycin. The physician decides to discontinue the streptomycin due to concerns about a potential effect on the fetus. So what do you guys think? Why did we stop the streptomycin? Someone said B. A or B? B, I think. Does it cause lymph malformations? Or did you just choose B because of teratogenic? No, but guys, why did you choose B? Is it just because of teratogenic? Okay, I understand why would you do that, but like it's A. Why? Because ototoxicity, it is, yeah. There's an antibiotic that causes also, I can't remember it. It is an aminoglycoside. Exactly. So streptomycin is an aminoglycoside and it causes ototoxicity. So it would lead to, it's teratogenic, leading to congenital deafness. But that's why it's A, not B. Because, okay, maybe like the ototoxicity is a teratogenic effect, but no, aminoglycoside doesn't cause lymph malformations. So you can't guys just jump to teratogenic effects. You get me? So that's why I read the other options. Don't just go with whatever you see first. So as we mentioned, streptomycin, they're an aminoglycoside, and aminoglycosides are contraindicated in pregnancy because of the ototoxicity. So if a patient is like pregnant and she takes aminoglycosides, there's a very high chance the baby is just going to be born without like deaf, like he's not able to hear because of the ototoxicity. Is this clear? يعني على فكرة the doctor can easily do that, like put teratogenic and you guys can think, oh my god, teratogenic, yay. But by then you guys lose the grade for it. So please read the question properly, like read the choices properly. تمام? تمام. I'm sorry guys, I know you guys are all tired, I'm tired too, but ما بي كتير. So a 47-year-old male with multi-drug resistant to TB is started on a regimen that includes a second-line anti-TB drug. This anti-TB drug causes psychosis and convulsions. So what drug do you think is the second-line TB drug that's given? No clue. صراحة slay. هو صراحة D? Are you guessing? هو صراحة this is إحساس B. They didn't focus on them. خلاص, if they didn't focus on them, then just, I guess, skip. But it's A actually. And it's in the what is it called? Table. It says cycloserine causes like it affects the central nervous system فبصير في عنا psychosis, seizures and depression. تمام? If they didn't focus on them, then خلاص. Like you can just read them. Okay. A 55-year-old male diagnosed with TB begins treatment with a standard regimen of RIPE. However, after several weeks of therapy, the patient condition worsens, and testing reveals that the strain of myobate is resistant to isoniazid. Yeah, guys, you're right. It's A. Slay! So resistance to isoniazid is on CAD-G gene. I think it was mentioned before in the exams, right? Like they like this. I feel like doctors like this. Anyways, okay. I know it looks really long, but guys, optic neuritis, ethambutol. What do you guys think? What's the mechanism of action of ethambutol? B, 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 B. Do you guys think it's B? Slay. You guys are right. It is an arabinosol transferase. Guys, I've always حفظت إنه ethambutol, like etham. It sounds like an Arab name. So arabinosol transferase. That's how I memorized that. So I hope it sticks. Oh my god, no way. I guess we're all the same, I swear. Okay. So عنا a TB patient and then they have joint pain and swelling, specifically in the big toe. So we have gout. وعنا elevated serum uric acid levels. C. Exactly. It is pyrazamide because it causes hyperuricemia. So it can cause gout-like symptoms. They love, guys, they love TB drugs. Even in step one, they love TB drugs. A 50-year-old female presents with a chronic cough that has persisted for several months. A chest X-ray shows a peripheral mass in their right lung. A biopsy is taken, which shows adenocarcinoma. Molecular testing reveals an EGFR driver mutation. Everyone's saying A. You guys are right. It's erlotinib, E mutation, E drug. حبات. E for E. Slay. So the patient has adenocarcinoma of the lung, which has an EGFR mutation. So we want to give them something that would stop the EGFR, which is erlotinib, which works. Is this clear? The other drug also starts with G, EGFR. صراحة, she's giving us a crash course. So guys, E mutation, E drug. Another drug also starts with G, EGFR. حبات. 10 out of 10. This is, I think, the last question. I hope so. Because صراحة حسيت إني تعبتكم معي يعني. So, a patient has lung cancer, okay, and he's given bevacizumab. What is bevacizumab, guys? What it works on? What does it inhibit? C, maybe. It inhibits angiogenesis. صح. So, VEGR. Yeah. So, VEGF. Yeah. So, if a patient were inhibiting VEGF, where would I contraindicate such a medication? C. صح. Because basically, if we have a recent surgical procedure, then we have like an incision. We're gonna have delayed wound healing. صح. Wallah, guys, you're like slaying. So, yeah, that's it. I hope, guys, I helped you in this session. عملنا like a شو اسمه like a review of all of the drugs. Guys, please scan this code and give whatever feedback you have. I would really, really, really appreciate it if you guys scan it. But please, please scan it. And this is my number and my email. If you guys have any questions, just text me. I would love to help. I'm going to send this if you guys want the PowerPoint. I hope it was helpful. I hope it wasn't really like the questions were really not super easy. I think we can stop the recording here. خلاص. Bye guys.